communication of a medical oncologist with a pathologist, also, by the way, with the surgeon, the pulmonologist, and the team that is obtaining the biopsy is critical, the radiologist. And the reason is lung cancer, all tumors have become personalized in the way we treat them. And it's very important to know which markers are important and to have that information up front. It's also an ever-changing field. The techniques used have to evolve, as new discoveries are made. So we're very fortunate. At Yale Cancer Center, we have many things that facilitate communication between David and myself. We have tumor boards, and at those tumor boards, we present cases, and one of the components of a tumor board is a pathology review, a radiology review, and then a clinical discussion. So that's done on a routine basis. But more important, I think, is in what makes a hospital like ours very special is the research infrastructure. And I'll just focus on lung cancer since it's what I know best, but we're doing this in all areas. So we have a lung cancer research working group. We call it a DART, a disease-aligned research team. So we meet, on a weekly basis, and we discuss what's new in lung cancer, what are the markers, and we realize that there's a panel of markers that you need for basic clinical care. I'd like my center to be one where if a patient comes, he or she gets the most up-to-date care that includes EGFR, ALK, ROS, RET, MET, BRAF, HER2, and these things we all have drugs for. But there are many things that are still in the investigational stage that are also important to know. So then we have a second level of testing. We can test 136 genes using a next-gen platform. We can do a whole exome if that's necessary. If tumor mutational burden is relevant, we can do that as well. That would be a special order, but we'll do that as the data evolve. And what happens is David works so closely with us, both in the clinical and research setting, as part of our lung cancer research effort, our specialized program in research excellence. We're doing research. The way we're going to push the field forward is to develop those predictive markers for immunotherapy. So early on, when we were doing the first phase 1 trials, we got to know each other. I didn't know David 8 years ago that well, but we started to work together, and we said we have to develop PDL1 assays. And David, in his usual style, developed 10 of them and told us which one was the best. And he's now, I would say, one of the best experts on how that works. So we really dove all in. But that helped the clinical care because we were one of the first hospitals to have PDL1 running. In fact, we can get a PDL1 test for a lung cancer patient quicker than we can any of the other tests I've already mentioned. And that's important because when drugs became approved based on biomarker, or the biomarker helped us to inform whether or not we should use combinations or not, we were already in that situation. So it's really a wonderful collaboration. The only concern I have is that there aren't more pathologists who work like this. And I'll tell you, for the research effort, it's critical. If you're not thinking about how you're collecting your tissue, thinking about how you're going to analyze your tissue, multiplexing your assays, we can talk about that. But there's only a limited amount of tissue there, so you've got to prioritize them and multiplex it. So these are all things that we do with David.
So one of the things, Roy, when we perhaps most often meet is that Roy and Li-Ping Chen run a specialized program for research excellence at Yale, or a SPORE program. And that gets us together a lot in the context of research that's interesting that has potential to translate. A SPORE program by design is supposed to be translational research. So we're taking the things that we're discovering in the basic labs and then moving them to the clinic. And that's where we interact a lot, informally and formally, in terms of presenting what's new and then how we're going to help patient care with that assay. And so it sort of goes both ways. From the patient care, we work toward developing assays that are used on a regular basis, and then from the research side, we're working on developing assays that can be tested in the clinical setting.